pain. So I say this case, I don't think this tooth is a problem unless there's some period pocket, very little pocket, some bone losses. So I do my clinical exam. I always do an X-ray. Don't believe the X-ray somebody give you, okay? First is the quality. Second, you're not sure what something done between two X-ray was taken. In this case, I do pop testing, TTP of it. The tooth is all normal except a little bit sensitive. But you can explain the exposed teeth. So, is it pain caused by 3-7? That's been done for many years. I don't think it causes spontaneous pain in this case because there's no nerve inside. So I took an OPG. I always took an OPG for my patients. So I suspect there could be some pain on the upper lip. Because we know that pain only refer up and down, not across the midline. So usually I check the teeth on the upper. And I suggest could be something wrong with this one. So I do EPD on the upper arch as well. I find this one abnormal reading from the EPD. So I have a close check of the tooth. Under rubber dam, I can see some crack lines. So I tell the patient, your problem comes from this one. Do you think she believe me? Usually not. In the first encounter, I say, I don't mind, go home. Okay? I think you have problem with upper teeth, not the lower tooth. Go home, talk to your husband, because usually the husband pay for the bill, okay? 2 days later, she come back, and okay, try to treat this one. So I say, what I'm going to do, I give injections, I remove the amalgam, I check for the cracks under the fillings. So, this is my diagnosis. So I open up, I can see cracks, I can see necrotic pulp, so I know I'm the correct entry to this endo. So endo was a finish, and the patient no pain. Another thing very important is that before you start any treatment, no matter it's a restorative or orthodontic surgical, you need to have baseline what will happen. Let's say you're going to pull out a tooth. You need to know what's the tooth look like. Okay, how many roots? Is it 3 rooted, 4 rooted? You need to take everything out. Endo, you need to preview your success. If you don't think you will be successful, you should not do that. It's a case. A patient in Taiwan for a long time. Endo was done 20 years ago with a crown. Some implants done in Hong Kong. And he complained. He started with some discomfort with this tooth after 20 years. So look, to me, it's very unusual. The tooth have been okay for 20 years. What goes wrong? So I do a more examination. Look at this. You can see it's a general adhesions, which means the patient might grinding. So I asked him to grind the teeth. Most of the patients say, I don't know. Okay. So you check, you can see the canines guidance was lost. So the patient have I suspect it's a nocturnal grinding at night. I pick up my peripheral, check the tooth. I can see a deep pocket on one of the molar. That is the molar cause the pain. So my diagnosis is a vertical root fracture in this case. No matter what you do endo, this case will fail. So this is an extraction case. Before we start endo, you need to spend a lot of time, more time in your endo evaluation, including length, curvature, bone support, calcification, can I find the canal? Most of the time, people refuse to me because they can't find the canals. But you should do an assessment before you start. It's more embarrassing to tell the patient, I can't finish the case. Okay, rather than tell the patient, I can't do it, you better go for somebody at the first hands. Whether remaining structures, I can restore the tooth. A lot of colleagues, they save the root. But however, the root cannot be restored. There's no point to spend a lot of resources, including money, time, and patient expectation on our side to do and treat the tooth that's hopeless. So in this case, it's the 2 canals. If you ask me, I don't want to do it, but the patient has the problem. And we know that this Learns premolars is very popular in our Asia. So I have to do this. In fact, this is a 3-rooted lower premolars. I look at this case. The young patient came to me. I don't want to do it, okay? Because you can't see the pulp. I'm sorry about the LC projector, but we hardly see the pulp. Okay, I don't want to commit, but the patient in pain and is young, he's only about 20 years old. I don't know why, what's the classification of the pulp chamber. But the case comes to me, and I need to do endo. So it's quite a difficult one. I spend 4 to 5 hours working on this tooth. So a lot of time to look for all these canals and finish the case. We are not Superman, we are not God. Okay, some cases too difficult to manage, you should consider referral. Okay, refer somebody have the training, experience, or somebody you hate. Okay, I don't like this. Okay, I give him a very difficult case, so make him a really hard time. Okay, or consider exceptions. Sometimes you need to talk to the patients. There's no reason patients select for endo or select for extraction. It could be financials, it could be time, or it could be endophobia. Okay. There's no hero in endos. Okay. We are only doing endodontics. Okay, not periodontics. Okay. Don't be a hero. I would say, I can give you some recommendation. If you run into a periodontics, you end up with a lot of complaint cases. We are, I would say, old enough, okay, to give you some advice. Okay, some cases you treat it, you end up with a lot of complaint from the patients. So you need to know your limit. Second important key issues is the rubber dam. Okay, I know it's not very popular. Even in our area, only 30% dentists using rubber dam for endos. But this is a very important step before you commence any endodontic treatment. Okay, you can prepare a curved canal, very beautiful, but without rubber dam. Sorry, I got a case sent to me by a China endodontist. He sent me a case, very curvature, 90 degrees. He finished. He wants to say, I want to publish in a journal. I say, okay, but you need to do it again. I say, why? Because in your X-ray, there's no rubber dam. Nobody will accept your case report because it's deviated from a standard practice. So rubber dam is very important. Why? Root canal infection, in fact, very simple. The bacterial species only about 2 to 8. But your saliva and your oral cavity get more bugs, get more bacteria. If your saliva goes into the root canals, it may complicate the success. And also, without rubber dam, sometimes with the troubles, a file was inhaled or ingested. Okay, they will end up with no defense. So you need to have the rubber dam for the patient. And more than a rubber dam, we need glasses. Okay, we are using some caustic solution for irrigation. In a supine position, you may drop to the patient's eye. There was a case report. The dentist got the sodium chloride into the eyes. Dentist himself. So you need to protect your patient, your nurse, and yourself from any potential injury. And put a full bib, using a full bib. Because patient might come with Armani suit, okay, like this, okay? You got some bleaching agent on the suit. You have to pay back the patient for the damage. So you need to protect the patient in a more wide aspect. There's many techniques in endos, but the precautions only say. Rubber dam have been used in dentistry for 150 years, more than 150. If something to survive for that long time, it must have experience. So that's my advice. American Association of Dentists, the position statement, you must use it, okay. If we have colleagues from Australia, you go to Victoria, they make it easier. If you don't using rubber dam for endo, you are professional misconduct. They can sue you. No matter how good is your endo, how successful your endo, if you don't use rubber dam for endo, you are fired. Okay, it's very strict. There's a study saying patients like rubber dam, but the dentists, they do not like. There are a few reasons. The dentists respond to survey that why they do not using rubber dam. Depends to like it. Patients do not like it, but they don't get the patient a choice. Not necessary, they think they can do it. Difficult to use, time and cost. Okay, this is a rubber dam demonstration. In one of my cases, I putting a rubber dam on second molars or lower. For those people who are in the clock, we can use 20 to 40 seconds to finish the applications. So I don't think time is an issue for a single tooth isolation for rubber dam. Material cost is very cheap. Okay, rubber dam doesn't cost much. So even I'm trying to make sure that the rubber dam does not leak. So I will adjust the clamp to make sure that it's not leaking around the rubber. It takes about 40 seconds up to down. So the thing is important to spend this 1 minute, I would say so. Once the rubber dam on, you can relax. Patient cannot talk, okay? So you can stop the patient from talking. Hey, doctor, okay, I can't hear you, sorry. They can go to sleep. 50% of my patients fall asleep. No IV sedation, okay? They just put the rubber dam, keep it quiet, it's set. Okay, Hong Kong people are too tired. Okay, but it's very effective if you're doing two-handed dentistry. It's clean and easy. You can use only one hand to do it. Because anything is isolated, you do not see the tongue, you do not see the lip, okay? And you're concentrating. And a lot of situations, you still can apply rubber dam, although it's not ideal. But you still can prevent your instrument from dropping into patient's respiratory tract or GI tract. So even orthodontics, I can still apply rubber dam for that. So if you have rubber dam in your office, you lost it, try to find it. Somebody can help you, okay? The third step, I would say, is magnification. Third issues. Most of people are young, okay, they're young. I'm relatively old, although I'm more senior here. So we need magnification in the endo. Why we need magnifications? Very simple, we can't see. Okay, the endodontist got a very hard job. Okay, patient comes in, there's a hole. Inside the hole is a tooth. We cut another hole into the tooth. Inside the hole we have the canal orifice. So it's a hole inside holes inside holes. So it's very small and you cannot see. This is a case, you can see it's a topstone, you can see the canals. We need to search the canal, we need to remove all those obstacles that deny your visual discrimination. This is a Hong Kong $100 notes. If you have in your pocket, this we call HSBC Bank in Central. 125 magnification, not very, it's not massive. 25 times magnification, you can see the wording here. It's a Hong Kong and Shanghai Bank Corporation. So that's $100 note is real, okay? 20 times magnification, you can see the details. We open up the tube, you can see the cracks. We can take a picture and show to the patient. This is a crack, okay? They are more willing to pay because you show them the diagnosis. We can see the fracture instrument inside the canal with the magnification. This is a case. Patient have the endo done and crown done in last month, but with the persistent symptoms. So open up the case. Sorry. Open up the case. It's an overfilling, but you can see there's still some pulp tissue remain between two canals. This is narcotic tissue. It consists of bacteria. It contributes to the discomfort by the patient. Why? Because the dentists do not see the detail. They have no time or no effort has been spent to clean up all these narcotic tissues because it's magnification. We not just feel, we can see. I still remember in 80 when I do my training, my professor sit down to look for canal for me. Okay, he just sit down and doing that. And then he find the canal. I said, how can you do that? They look at me very seriously, experience. Okay, now you will tell the patient that I'm not sure whether I can see the canal, but I try, I guess. What the patient do? He will go away. In my referral letter, a lot of colleagues refer case to me. Notice at the last sentence, what they say, please using microscope. I don't understand why. Because all my case, I work endo under microscope. I don't know why. Later I realized, because the dentist said to the patient, this is a difficult endo. Dr. Chen have an instrument called microscope, so he can find and see the canal. If I have a machine, I can do it for you. But unlucky, I do not have the machine. So you go to see Dr. Chen. So it's an excuse for the dentist to refer the case. So I was using microscope. You can have a choice. I'm not saying you have to buy a microscope, okay? But you can consider using loupes. A lot of surgeons, even now orthodontists, using loupes. Why? Because the new self-ligating bracket have a little button. You have to press it and then open the lock. Most of the orthodontists cannot see the button. So they buy loupes, see the button to press, okay? So I highly recommend you start using loupes, okay, to improve your dentistry. For example, Every case before my obturation, I clean the canals, I dry it, I will examine under microscope to check anything missed or anything left. Okay, I will see this one is an MD1, MD2, all canal are clean, free of any visible debris, and it's ready for obturation. For young guys, these are our students. I would like to take picture of my students before, okay, see how they're working on patients. Like this one, I say you're kissing the patient. And this lady, you can see how she bent. This guy, you know how heavy our head. Who knows what's the weight of our head? It's talking about 8 to 10 pounds. My head is bigger, so it's more heavy. If you bend like this, you will have pain. That's why it's early retirement. So I'm sure that Professor Long had very good posture. Otherwise, he retired 20 years ago. Okay, we have a lot of young dentists. They need to go to massage after work. Why? Look at this. Okay, this will cause a lot of muscle pain. They're young. This is only 18, 20 years people. But when they work like that for another 10 years, they have to retire. So we need to do that. And they're young, they do not have a problem called the presbyopia. Okay? When you're young, you can still see. I'm old. I go in, I can't see. I need to go back, right? If I go back, it's too small. Okay? Too small, I cannot see either. So you need magnifying glasses for that. Okay, one of the study, I do it, I think over 10 years ago with students. Yes, exactly what she do in the lab. Okay? She's just like a boxing gun. Okay? It's a lady. So, that kind of student, I give a pair of head mount loops. And I measure their working distance and posture again. And they have to fill up some survey. We got very positive feedback from the students. Once they realized, she didn't know that I take this picture. But after that, she realized how more comfortable, well-supported posture for dentistry. And you have better infection control. In that case, the patient got infective aerosol, you were the first one to get infected. Okay. So in some cases, with the magnification, I can find those missed canals. This case refer to me, and you see dentistry 2 holes, mesobuccal canal. But in fact, the mesobuccal canal is more meso. So we open up the magnification, I can find the canals. It's a 2-rooted 2 canal lower incisor, that's why it fails. So 2 canal were fine. More important and most important application of the magnification is the fracture instrument removal. Some colleagues say, I would like to try to remove the file. I say, how do you do that? I buy some tips from Dentsply and I work. I say, don't do that. If you cannot see the files, you cannot remove it. Don't think you put an ultrasonic tip inside the orifice, you vibrate someone to come out. No, life is not that easy. Okay, you need to see the files, then you have a chance to remove it. If I cannot see the file, I will not be able to remove it. It's my advice. So we can see our target. I can see the files, and I can remove it. It's a case with 2 separate files. So in the beginning, I'm saying this is more easy to remove because it's bigger, and the distal canal is larger. In fact, I'm wrong. I spent 15 minutes to remove the one from the mesial, and spent 3 hours on this one. Because the canal is very big. I vibrate it, it goes further, okay? How can I manage it later on? Okay, something the best about endodontics, different from oral surgery. You have 100 reasons to close it and do it next time. Oral surgery, you start your cut, you have to finish. Endo is different. I can close it and I'll do it next time. Chinese, you believe the Chinese calendar, right? Find a good day in the Chinese calendar. Sometimes they say this day do nothing, right? It's the worst day of the year, don't do anything. I'm joking. The best day is the first patient of the day. And you spare more time. Let's say I spend 1.5 hours. I know there's no patient in that period. I'm more relaxed. I'm not stressed. So I can concentrate in the first day of the case, and you can remove it and finish. Okay? Another case, separate taper, even very deep, we can see it's a triangular shaped file, so it's a taper, so remove it and finish. Working length. Okay, if you do not is important. You are wrong. We are doing a root canal. We need to know the working length. How can we do that? Someone give me tactile sense, okay? Paper point, X-ray, and electronic. Tactile sense doesn't mean that you don't give LA, right? And put a file. Ouch! This is not tactile sense. When you do 10 angle a day, you can feel the apical foramen with your file. You can feel it. You can feel all of this. So you need more training. A good point to test the working length in electronic cases is a paper point test. You put a paper point, if the paper point go out to the PDL, it's a little bit blood. Okay, it's not for vital case because a lot of alcohol tissue, but for non-vital case, for example, open apex, you're not sure about working length. You put a paper point, you guess it's around 18, so you go 18, no blood, 19, some blood, 18.5, no blood. So you know the range that you're working is about 18.5. So, but you need to be very gentle, okay? Otherwise, there's a lot of blood like this. X-ray, everyone take X-ray. It's illegal to do endo without a working length X-ray. So you need a good X-ray to show your working length. However, when we talk, say how to find the working length, usually the teacher say take an X-ray to try to work about 0.5 to 1 mm from the radiographic apex, right? That's what we learn. But however, sometimes you find that the apical foramen is not exactly at that range. Your X-ray looks perfect, but your file will be out in the PDL. That happens. So by chance, you may run into the problem in the working length determinations. So you need a good X-ray. Hopefully, you can just take one X-ray to get all the information, but life is not that easy. Okay? Sometimes you need to take more X-ray to see the detail, because this is only 2D real life. You have some problem tooth. Okay, sometimes if two files overlap to each other, you can't tell which one is mesobuccal, which one is mesolingual. What's the teeth give you this kind of problem? Upper molars, when they have two canals situated in the buccal and lingual plane. Mesobuccal root, upper molar sometimes two canals as well, lower incisors. Meso or distal root of lower molars, when there are two canals situated in the buccal lingual direction, you may have overlapping. How can we correct this problem? Very easy. One canal each side. I have a student, she spent 6 X-ray on the lower molar, but she still can't find the working length. I said, why? It's all overlapping, bone cut, a lot of reasons. I said, this molar only have 3 canals. If you put one file each time, 3 X-ray will be done. You are too greedy. She tried to get all information in one X-ray. She spent 6 X-ray, still can't get the answers. Some people ask you to shift the cone, right? Stop rules. I'm not very good. I'm very poor in direction. So, but you can do that. You shift your cone to one direction. They will separate the buccal and the lingual canals. In this case, I can separate two. They are not overlapping to each other. But a very easy way to distinguish those two canals. Try to using two files with different configuration, different size, so we can see it's two different images on the X-ray. It's more easy. Don't put two identical files. It just makes yourself more difficult. In this case, two files that look different. I know which one is buccal, which one is lingual. So if you know patient tomorrow, put all your endo instruments, take an X-ray. See how they look like. Okay, this is an X-file, this is a verifier, this is a spreader, this is a K-file. So you can see they look different on your X-ray. In this case, I know H-file was put in the collector canal, K-file was in the buccal canal. So they tell you which file represents which canal. So it's a clinical tips. Or you have still struggle, one on each side. This is mesobuccal, distal buccal. Mesolingual, distal lingual. So your life is less stress. Apex locators, now is a standard instrument we use. Okay, if you do a lot of endo, this is one of the instruments I recommend you to buy. The system I use is from endo because you have two functions. It's an apex locator and the electronic clock testing. So we have one machine have two functions. Why we need to use apex locator? there's some good indication, or you can say it's advantages. Sometimes the X-ray, we cannot see the apex. Even if it's a good X-ray, like the upper maxillary teeth, sometimes you can't see where is the apex. So we can't tell whether your working length is correct or not. Some patients not very cooperating. You cut the X-ray, you put the X-ray, okay? So this is the worst patients. Some people do not want you to take X-ray. People are now very radiation phobia. A lot of patients, they need thyroid shield, they need a lot of protection before they take X-ray. They will ask you how many you're going to take. If you take more than that, they will be very upset. Okay? Some pregnant women, you still have to do endo. You make them feel more comfortable. We try to cut down the X-ray as well. Okay. Also, we help us to diagnose perforations because apex locator can measure the resistance between the canal and the DDL, periodontal ligaments. If there's a perforation, you give an early reading. For my clinical practice, I always using the apex locator to determine its working length. Then I take an X-ray to confirm. Some cases I do not take an X-ray. Okay, but if I do not take X-ray for the working length, I will take X-ray on the master cone, the GP cone. I will take X-ray. So I need at least 3 X-ray. The first one is beyond. Second one, you need an X-ray to show the working length, either with an orthodontic files or master cone. The third one is the after operation. There's a minimum, okay, by law, minimum. You can take more than that to help you to confirm the working length. But if you take less than 3, you might be in trouble. Sometimes it doesn't work, okay, if you got a big metallic filling or there's a crown, for example, because it's a machine measure the electricities. So if some leaking fillings also give the false readings. So I'm too fast? Okay, survive? So I finished 4, I have 6 more, okay. X-rays, okay. Endodontist or dentist cannot live without X-ray. But we need a good X-ray. I show you examples. This is my classmate. He sent this patient with this X-ray. So I said, do you have a better one? I give you the best one. Okay. So in this one, I show you examples of really how bad is an X-ray. Okay. Poor positioning, you can see a bone cut. Poor processing. Poor handling. Okay, of course, he's not using rubber dam. Your X-ray should be no distortions because you need to measure the length. You can want to see the tooth angles. You want to see the curvatures. Then there should be no distortion, so you can have a direct comparison between the pre-op and the post-op. This is a case. The dentist referred to me with this X-ray. They say the 3/6 has some abnormal anatomy, so he is not confident to do it. But it's not abnormal anatomy, it's only because the way he takes the X-ray, the tooth is a bit distorted, the X-ray. It's really straightforward endodonts. Once you have a good X-ray, you can take it. So don't do it again. Remember this, colleagues? This is my classmate, we graduated 24 years. Since he graduated, never using cream holders. In the dental school, we're using cream holder, something like this. He never use it. Well, one day he called me, he want to buy a cream holder. Any recommendation? I say, why? You haven't used it for 24 years. Why you to buy it? He said today the old ladies, you want to take an X-ray like this. Okay, that's what he do. Ask the patient to hold it. The old lady said to him, hey doctor, would you mind holding it for me? I'm too old, you know. I'm worried that I'm holding in the wrong position. She's very sincere. Please. My friend did not hold it for him. Okay, you know why? Patient always asks, why everybody go away, right? I will say to the patients, you only have 1 X-ray today. I have 20 patients a day. Okay, so I have to go on. So I do not recommend you do this because it will increase the retakes. Because it's not a good X-ray, sometimes difficult to position the X-ray tubes and unnecessary to patients' hands. Okay. So try to listen to some sort of film holders, and most of the film holders have been decided, even rubber dam was used, you can still take an X-ray. There's no problem. Okay? And also, if you're still using the conventional X-ray, try to buy this X-ray viewers. It's very cheap, okay? I would say about $100 US. I can use it for life. You don't drop it, okay? You drop it, there's no guarantee. There's a 2 times lens inside. And you can plot all those lights so you can see the details of the X-ray. For my student, they have to show me that they view the X-ray with this viewer before they ask me any questions. A lot of dentists doing that, right? Okay. They say, oh, good. No, this is a more professional way to do it because you want to see more details. How about digitals? Okay, it's a trend in digitals. I'm using all digitals. It's very useful in intraoperative and postoperative. So this is a master cone, sinus tract tracing with the GP cone before we take the X-ray. So you can see how we can position the film holder in a true parallel technique. So, what's the problem with this case? I'm sorry about the quality on the screen. This case referred to me. The dentist practiced endodontics in the top horns. So the top is still there. He cut the cavities and see a few pop horns and they just do the endo. So he have not removed the whole upper wood. There's some wood filling here, sorry. The upper wood is still intact. This is the pulp tissues. Endo was done, crime was made, but it's not a good case. It's a case referred to me. I'm sorry about the qualities for endo on this one. I was distracted by the implants. I hate implants, okay? And the dentist hate implants. I was distracted. They asked me, can I do this one? I said, of course, no problem. Because my attention was attracted by the implant. So I committed to do this retreatment on the 3-7. In the second visit, I really start my treatment. I know I'm in problems because there's a fracture instrument here. Okay, sorry about the resolution. My screen is much better. There was a fracture instrument I did not notice in the first appointment on consultation because I was busy, I'm tired, I was distracted by this implant. Okay, so my excuse. So in the second visit, I think there's a fracture file. Some of the software can ask you have a 3D mode. So you can see there's a pieces of instrument can stand out from the GP. So it's a fracture instrument. So I spend more time to remove it. So I cannot charge with it because I didn't give any quotation of the separation. I'm misdiagnosis. Okay, it's my fault. I always take OPG. Okay, so this is one of my friends. He came to me on fracture tooth, see whether I can save this one. So I take an OPG and I see something here. Okay, so quickly we look at the patient as a clinician check. Okay, what happened? Okay, everyone know what's this? In the dental school, it's called spot diagnosis. Okay, if I put it on exam, no student will pass. Everyone can give me some answer. What's this? Don't say artifact. Okay. A lot of students say artifact, right? In exam. Okay, it's not true. Something else not belong to the patient. No, it belongs to the patient. Any ideas? Any ideas? No. This guy played ball game when he was young, and he got a shot on the cheek, and the bullet is still inside on the cheek. When I palpate the cheek, it's inside. It's wholly buried inside the cheek. So, because when I asked, what happened? You have this, can you measure, is it 6 mm in diameter? That's what patient said. So I measure, it's 6 mm in diameter. I said, yes, it's the bullet. Okay, he knows. This happened 20 years ago. So it's a bullet on his face. So in endodontics, now a lot of people argue, should we using cone beam CT or peripherals only? So a lot of people still fighting to each other whether we can expose the patient to more radiation in order to get more information. I told you I got a cone beam, so I'm more for cone beam side. I could be a little bit biased because all your X-rays only 2D. We are working on a 3D optics. It's a tooth, it's a molar. Even I can ask you, and you know it's more difficult. And I would like to know what's the involvement into the root canals. So the cone beam CT told me that it's on the buccal side and they have extended into the top. So when we formulate a treatment plan for the patient, we need surgical repair, we need root canal because the lesion is very deep. So AAE also have a position statements. They said they agree that we should using cone beam CT to improve our anatomic treatments. So this is my setup, okay? This is my cone beam CT, this is my intro. I cannot make money with this, okay? The warranty just expired. So I just calculate how many cone beam CT I've taken. In the last 2 years, I take about 500 cone beam CT. But this machine costs more than that, okay? But it improved my endodontic treatment and endodontic diagnosis. I'll show you some cases. This lady was referred to me for endo on this one. It's a new bridge made 2 months ago. Patient lost two premolars, and the bone quality is not good for implants. So the dentist put a 4-unit bridge, but she's in pain. So dentist is worried because patients are upset. They spend a lot of money on the bridge and the pain. When the dentist started the endo on this one, he couldn't find any canal. So he's worried, so he sent the case to me. If you look at this one, I cannot see the canal either. So I think at cone beam CT, you can see the bone quality. Maybe he can do some augmentation, but it's more extensive than the treatment. But on this cone beam, I can see there's 4 canal. Okay, so I'm confident because the canal were there. So I go in, I can try to find it. In some cases, we go through the whole tooth scan. We cannot see any canal. I send the patient, the chance we find the canal is very minimal. Okay. So the case was finished. It's 4 canals, upper molars. Patient happy because we can save the bridge. Dentist happy, the patient will not complain. Another case, I was referred to remove a separate instrument. So it's a separate instrument to taper again in the mesial root. So I take a cone beam, I can tell that it's on the mesial buccal. So I don't need to search. I know it's on mesial buccal, so I can go directly to remove it. And I tell the dentist that you missed one of the canal because they told me there's 3 canal molars. In fact, you missed the mesolingual. Okay. Distal canal. He missed it in his last endodontic trip. So I told him that there's another canal. In this case, he just paid me to remove the file. Sometimes I take cases, I just remove the file from the patient. And the patient go back to the dentist to finish the root canal. So I can see the file, you can remove it. This is a case referred to me for cracked tooth on 4-7, and we subscribe a C-shape configuration. C-shape is very popular in Asia, everyone knows. So we see cases, and I think it won't be to confirm the C-shape because C-shape is more difficult to manage, and usually we charge more. And you can show to the patient that what's mean by a C-shape and how is the difficulties. So they're more willing to spend the money in your office. So we finish. Patient benefit, I would say we can improve the diagnosis. From the operative side, I can shorten my appointment. Because in the past, if I'm not sure whether it's a 2nd or 3rd or 4th canal, I will spend at least 15 minutes to search, to find, and might cause more damage to the case. But now I know there's a 3 canal. Again, if I can find 3, it saves my time. Endosonics, okay, we use a lot endosonics. I'm not saying you must use endosonic for your whole endo cases, but I just show you what it can do for us. We need a driving force. It's a normal ultrasonic scaler, okay? But the difference is the tube you put onto the handpiece, okay? Different tubes you can use. Because of the cavitation and topic streaming, we can improve the cleaning of the canals. Different tubes, they are really small. These are only 3 mm in diameters. Humidify, you can see it's coated with the nitrate, so it's very hard substance you can use for cuttings. Okay. Post and core cases, remove you can see the core material. Ultrasonic can help you to remove all those core materials, and you use to loosen the bones when you come out, rather than using a burr to cut. This is a video from Keith Rodos. how we're using ultrasonic tips to look for MB2 canals. When we're using endosonics, we use it dry. Okay, there's no water. You have to stop the water. So it's dry cutting. We're troughing with very small tubes. We suspect there's a canal there. Once you remove the superior secondary dentin, you can see the possibility of entry of the MB2. So you can put a file in. It's a very conservative cutting because you're using a bird. First, you can't see. Your APDSA head will block all your visions. But with the endosonics, you have a very good visual approach to your working site. So you can put your second file into the MB2 and find the canal. But something I would suggest you to do, I would call the endosonic cleaning. This is immediate after preparation, where a lot of debris, very dirty. We put some bleaching agent, there's irrigation. This is a scaler. I put an ultrasonic scaler without water. It's just vibrating inside. No need to touch the dentin, just the vibration, acoustic streaming, cavitation will help you to clean all those debris with the help of the bleaching agent, so they have chloride. Just a few seconds, I do not add it, it's 10 to 20 seconds working, and you rinse out all very gentle. Briefly dry. You can see how clean. Okay, it can help me to remove most of the debris in a very short period of time. Retro prep, I'm talking about this tube, you know, 3 mm. Under magnification, after osteotomies, you can do a very controlled tiny preparation on your epicentomies. Irrigations. We don't know our file, our instrumentation cannot kill materials. We can only physically or mechanically remove it. We have to rely on our chemical cleaning. Okay? We need a chemical cleaning to achieve the success. For example, between two canals, a lot of debris. Okay, we call it isthmus area. We have pulp tissue that's not accessible by the files. So you need a chemical agent to do the job for you. Okay, what we can use? There's a thing I use. It's not water, okay, it's a hypochlorite, it's a bleaching agent. I'm using 1:1 concentration. So 1 part of bleach mixed with 1 part of distilled water. So it's about 3%. Somebody asked me why 1:1. It's not ethylene based. I just make my life easier, make my nurse easier. Okay? If you tell the nurse 1 part of bleaching, 5 parts of distilled water, they do it the correct first day. Second day they mix. Okay, 5 parts of bleach and 1 part of water. Okay? So 1 mix. So it's easier. Sodium chloride, very good antibacterial, bleaching, lubrication is still the #1 choice. Although there's a lot of research on other alternatives, but it's still the best and the most cheapest, okay, for the irrigation. Sometimes using EDTA is a chelating agent to open up the dental tubules. Sometimes using quercetines. I'm using Cossidils, but in fact, Cossidil, the concentration is too low. We recommend using 2% in research. Most of the mouth greens are only 0.2, but it's still a very good alternative. You don't want to be using sodium chloride in some cases. This is a fresh pulp tissue. Okay, well, the nerve from the tube. I put hypochlorite soaking is full strength at that time. It's immediate, it's 5 minutes soaking, 10 minutes, 50 minutes. So the pulp tissue is gone. So it shows you that the very good organic tissue dissolving power of bleach. When we're working on the root canal, inside the pulp is all soft tissues. So if we can using sodium chloride, we can help us to remove all those tissue in an easy way. Okay, you need a minimum soaking time 20 to 30. If your angle is too fast, okay, faster than 15 minutes, you do not have enough time. You need more time to soak and to dissolve the organic tissue. That's very important. So your angle should be at least 30 minutes to 1 hour. EDTA, this one is from Cytoendo, it contains 70% EDTA. Cetramines is an antibacterial agent. It helps you open up the dental tubules. So once you open up your disinfection, your sodium hypochlorite can go in to kill more bacteria. Also, as I said before, it's very safe, but however it cannot dissolve organic tissue. You should not use it for vital case, a lot of bleeding, because it cannot dissolve organic tissue. For the vital case, narcotic pulp, you can try to use it. One thing I need to remind you about the hypochlorite accident, although it's very rare, but it happens, is that we have injected those hypochlorite out from the peripheral foramen. That will cause intensive pain, even the patient under LA. This is my case. I'm working on one of the incisors for retreatment. When I irrigate, I admit that I'm very careful, but patients suddenly feel very pain. You can see blood from the canal. I know I got a hypochlorite accident. I'll show you another case for my colleagues. This gentleman have the root canal 23 upper canines on this side. 30 minutes, he showed armor pain, so the treatment was stopped. You can see some swelling here. Okay, immediate 30 minutes afterwards. So one day, it's a massive hematoma swellings. Okay. But I said to my colleagues, I'm okay, no problem. And my colleagues said, you got the problems. Okay, it's 1 day, it's 1 week, and 2 weeks. Okay? But I can tell you that it's a self-limiting problems. Don't worry, but you need to pretend to be calm, okay? Say to the patient, okay, it's an accident. Some solution go out from the apex and cause some disruption, but in a self-limiting, you should recover in a few weeks' time. I might advise that you need to manage it immediately with ProPack because the inflammatory response. Next day, you can try using ProPack just like your post-surgical management. Medication, we usually prescribe antibiotics because there's a big hematoma, you worry about the infection, stronger analgesics. Sometimes we prescribe antihistamine as well. I worry some of patients, in fact, they are some allergic to the bleaching agent. However, you would like to give corticosteroid, you need to be careful because in our region, prescribe corticosteroid, you need medical certifications. And you need to see the patient daily. Why I say daily? Because you don't want a patient to go to see somebody else. Otherwise, you keep the patient in the office. Okay, it's very important. How we prevent? You're usually using irrigation needle with the side vent and it should be very small. Okay? Don't jam your needle in the canal and squeeze it. You need to be very gentle. I always say endodontist is the most gentle dentist among the profession. In Hong Kong, they say the oral surgeon is the most rude. Very good. Because they got a big hand, usually. Okay, we have a small hand. I'm joking, okay? So, try using lower concentration if you worry. I've been an endodontist for 15 years. In my life, happened under my hand in 3 cases. So the chance is even lower than I crashed my car, okay? So, but it's still got a risk, you need to know. Preparations, why we have to do preparation? Because we need to remove all the organics. We still have to do preparation, we have no choice. Some people try to invent a system that no need to prepare the canal and finish, but it's still not successful for clinical use. So we need to prepare to shape the wall so we can clean. You have to open up the canal so your irrigation can go in. Without that preparation, your irrigation cannot go into the canals. And also we need operations. So I always say the file shape the canal. The file open up the canal and our irrigants clean the canal. So there's simultaneous steps. Everyone agree? Okay, if you're just using saline, normal saline for irrigation, it's just a mechanically flushing. The saline do not disinfect the canal for you. So we have hand instrumentation. I'm sure that in this part of the world, a lot of people using hand files. I've been brought up with the hand files. But hand files get a lot of problems. Okay? Because latch, transportation, from time to time you lost your working name, right? Everyone agree? That's why some people try to recommend a cramp down approach with the Volturi liquid titanium. I would say this will be the state of us in endo in preparation because it makes your life faster, easier, and quicker. We have no time to go into details about how we prepare the canal, but I'm doing another process in the next few days, somewhere in Cambodia. We go into detail about how we prepare and operate canals. So we give you more center preparation, it's quicker, so I'm more enjoying endos, less transportation, and we can achieve a larger preparation if you want. So it is a system I use, okay, but I have no time to go into detail, but what is good about this system because it's very flexible and very fatigue resistant. So which means very safe to be able to use. So in this file, we got twist file, it makes my twisting process. So I have no time to go into details. I can just show you videos, how we compare with other instruments. The file I use is called the TF. So this is a 90-degree bend. I heard or we call this block as a terminator because we try to finish the file, terminate the file. So it's an F2 from dense line. You go in the canal. Oh my God. So the adrenaline comes up, okay. So 3 seconds, the file was separated. So using similar dimension file from the TF, it's closing. No editing, it's real life, okay? Okay, separate. So, I would like to give you a message. All files will separate manufacture. If some sales reps said you my file never separate, it's only one condition, never use it, okay? So, if you can find a file that's more stronger, okay, that will be the choice. It's my recommendation you look for a system. I'm not saying that this is the best, but you need to look at the company background, whether any track record, how's the R&D, whether they conduct some courses to teach you how to use it. You like to drive a car, you like to ride a bike, you need to go for training, right? If I give the bike to you, if I don't teach you, okay, we won't see you again. Same thing. File, you need to know what's the strength and weaknesses of the systems. So you need a good track record. File with the more flexible and more cyclic fatigue to be the best. So this is my advice. The straight line access also is very important. You need to open up the window part of the tube first before you do anything. Without removing this canteen, your file bend too much and will cause a cyclic fatigue. It's a clinical case. Okay, I removed that canteen and I have a more straight line access in this case. Separate instruments. Everyone worry about that, right? There's a lot of reasons people do not using rotary. They say the rotary file will separate. I tell you, all instruments will separate. Okay. If your husband said to you, we will be together forever, he's lying. Okay. He only said to you at that minute. Okay. Tomorrow, the day after or year after, he may change his mind. Nothing in the world is forever. However, separate instrument is the most common dental legal complaint worldwide. Okay, I'm not sure what situations in Cambodia, but in our part of the world, a lot of people like to sue dentists nowadays. Okay, Singapore, I think, is very similar. US is the worst, I would say. It consists of about 28% of the claim, which means about 1/3 of the claim is talking about separate. Why? Because patients have the evidence that is instruments inside the tube. But however, I would like to tell you that your separate instrument is not a mistake. Okay, if you separate, you tell the patient, you advise how to manage, you should be okay, and you should get away from anything. So you need to be honest with the patients. There was a study find out that separate nickel titanium instrument is very similar to hand file, which means, in fact, you separate your hand file. but you just do not know that. I can advise you go back to check your file in the office. Most of the people will reuse their file, right? You are not single use. Any people single use hand file. Okay? So a lot of people now start using, in UK, there's a new law. All endo file need to be single use because of the mad cow disease. Okay? Australia is coming, as I know. So I will see the trend is that most of the file should be single use. Check your file, measure the length. It's either 21 or 25, right? I can tell you that about 30% of your file is not 21 and 25, which means it's separate already, but you didn't notice. Particularly those small size, number 8, number 10, you separate, that's why you block the canal. Why my canal is blocked, okay? It's not blocked last time, but this one is blocked because some part of the file is separate inside already. What's the reason for separation? Overuse. Okay? I tell you, all of you are multiple users of hand files. You are in direct usage. So, if you separate file, you need to do an assessment. Should I remove it, or should I leave it, or should I refer to somebody else? So there's a lot of reasoning behind. If you separate your file in the second appointment, a lot of people have multiple appointment approach straight endo, right? Multiple approach, usually you dress the canal, is less effective. So if I separate my instrument in second appointment or third appointment, the chance cause failure should be lower. If this is a narcotic case, very dirty, you open up your first file, go in, you separate. We know that the canal is very dirty, it's infected, then you need to remove it. But more important is the patient factor, the last one. How difficult is your patient? Some patients are easy, some patients are very difficult, they keep complaining. How to avoid separations? You need to using a good motors, reduce the number of use, good straight line access. This is the instrument I use. I'm sorry about the quality of the image. It's full of debris on the foot. So every time your file goes in, take out, you need to clean. Okay? If for those guys that are doing a lot of the hand job at home, you drill in the wall, your drill, you need to clean the drill before you go in again. Because once your drill is full of debris, it's inefficient. Implant is different because it connects the bolt or for augmentation. So you go in, you need to clean your implant drill as well before going in again. Okay, this is an interesting case. I always using a straight file going into the canals. Can I have a laser pointer? Just hold it. Okay, I put a straight file inside and I pull out, the file becomes bended. So if the straight file goes in, or go to the working name, I take it out. What does it mean? There's a hidden curvature inside your canal. So if you know that, if you're using your rotary or using hand, you need to make more careful. Okay, I didn't decurve the file, I just go in with a straight file and take out its bended. I will straighten it, do it once more, same curvature comes out, which means there's a curvature inside your canal. So you need to be careful. Also, we have a lot of new gadgets that can reduce the chance of separation. There's a TFA motor from side window. This I see a unit downstairs. This can reduce the cycle fatigue of your instruments. I tell you, stainless steel file always separate. This is some of my cases. I encounter this. I'm not the one to separate, okay? I just see, if you can see. Spar filler will separate. Okay. Even GG bird, okay, glazed Hindenburg will separate and retain. Okay? Very large pieces. Don't think, they say, oh, GG bird only separate at the top. No, sometimes separate in this part. So we have to pull a point, remove it as well. How we manage separate files? Anyone want to do that? Leave it, right? But if you leave it, you need to tell the patient. You need to tell the patient why you leave it, okay? And using a more good term in your record, premature obturation, okay? Or expensive nickel titanium obturation. Your file is right inside. This is the most conservative. You can leave it, but you need to tell the patient, and you have the reason to support it. Or you bypass it, okay? Get from the side, or remove it. So if there's a case, it's separate here. So I confirm and I remove it. It's a case, it's my cases. I separate TF here. I separate files, okay? Everybody will separate. Here's my case, I separate. In this case, I might pass it. So I got some space by the sides. Why I do not remove it? Because remove a separate instrument cause more damage to the tooth. So you need to make judgment whether I take a risk to perforate or to damage the tooth, or if I can bypass it, I will not remove it. Okay, another one is a number 10. This one I bypass it as well by combing CT. I can see the instruments. If I can bypass it, I just bypass it. If you remove it, it's not that easy. Filling the root canals. Everyone know that we have to fill up the canals. Many techniques. Should we using one technique? Okay, I would say the ideal technique is warm and bonded. The most important is that most of them with underfill will cause a problem. People say overfill, but I don't think so. I think underfill canals will cause more problem because it consists of necrotic tissues. So you can see the underfill cases, a lot of canal was not clean. So this is a case, a lawyer came to me, said, I got a root canal done recently. He's a lawyer, okay? So you need to be careful, he's a lawyer. The dentist, we do it twice, still in pain. I take a comb in, 3 rooted, 3 canal, I say fine, except a little bit area. Later you come back for retreatment. Okay, sorry. So I find a void in the root phalanx. It's not shown in comb-in CT. And I retreat it and it's okay. So a proper root phalanx and a good root phalanx, if you do a good job, anything will help. When we do obturate, 2 minutes. Okay? It's the same you should consider obturations. Patient no complaints. But if you're not sure, my advice is if you're not sure about the working aid or the success of cleaning, do it next times. Okay? Give the patient one more chance to heal. Sorry, there's no ideal filling materials. Nowadays we're still using a comb and a sealer. With no choice. So I'm not going into detail with this. I have advised that you need a better preparation. You need an 06 paper. Sometimes your paper preparation is too small, so you cannot operate to a good result. And you can achieve equals. There's only 2 slides. After reoperations, there's some missing steps. People do not restore the tooth. Okay, there's a studies that show that if you do a poor endos, okay, it's successful similar. However, you do a good endo with a good crown, the success rate is much higher. It's a 10% higher. Okay, so if you put a good crown on the patients, then you can achieve higher success rate for the patient. And you need to do your crown as soon as possible. A lot of people wait. You know, I do a crown next year, 6 months later. There's a chance you're going to separate or fracture the tooth. This is very common findings in dentistry. Patient come back with contemporary, the tooth is separate. Endo was finished, but the tooth was lost. So you need to protect the tooth. Okay, 50% of the case, molars, if you finish endo, do not put the crown. 50% 3 years will separate, will fracture. So, in my treatment planning, I'll tell the patient, you need to do endo. After that, you will need a crowns. Okay? My summary is that you need a correct diagnosis, case selections is correct. Then you have a septic technique with rubber dam. You do a proper cleaning, shaping, with the irrigants. Obturation is less important if you have done a good job in the shaping, but you need to do that and with good posterior crowns. What's the elements for good endos? You need to have good skills. You can try the new equipment and material, but you must be patient. Okay? Endo need times. The good endo need times. No 10 minutes molar endo. Molar endo at least 1 to 2 hours. Okay? With the help of magnification or elimination, you can improve your success. And you can achieve a predictable endos. And take home message, okay? Your success does not relate to any brand. I'm not saying that using Cyberendo I'm better than the non-technical. I'm not saying that using Dance5 better than the other company. More important, you need to under the basic biological principles of endodontic treatments, and you can guarantee your success. Okay. I hope you like endos. Okay. Toothbrush thing is a very worst job. Somebody don't like endo. Okay. Somebody like. So this is my email and website. If you have any questions, just feel free to contact me at any time. Sorry about the delays. So thank you very much.
Thank you. I really like the lecture because Alex re-emphasized one basic point. Materials and methods that you've seen, many of the companies downstairs, including those I mentioned, are in the exhibition hall. So after lunch, please see them and see what the latest things that you might have in endo management. If I had known Alex, I would have chosen endo rather than
decided to select something that as a new graduate or dentist who's just start practice can learn and can apply into clinical practice. Moreover, Dr. Peter Tai has got a global management group, which is a healthcare consultancy service and also so we will brief this also in the introduction. So please welcome Dr. Peter Tai.
Taught whole day you will see teeth, gums, wires, root canals. You can be good in that. Okay? But what's important is however skillful you are, how do you attract your customers to come and see you? What do the customers come and see you for? Is it just to see you to get rid of pain, get rid of swelling, get rid of no function? Why is it that a lot of customers do not like to see a dentist? Because they want to see certain things, because they have feelings. Remember, for young dentists, patients only buy your services when they feel that you feel for them. And how do you feel for them? By making your office and yourself attract their senses. Senses. You don't know by now there are 5 senses, you know. The eye, the ear, and everything. But how critical are you to notice them, to take care of them, what they want? So my presentation, no teeth, no gums, no nothing, it's going to be very fast, 150 PowerPoints, but a lot of them is like a movie. And some of you after this presentation will like me or do not like me. But you remember me. Okay? And the important thing here is don't expect to learn everything when you come to a meeting. Just learn one thing. And that's good enough. So every lecture you learn one thing. Because you cannot take too much things. Alright? Now, do not worry about what happened. Do not worry about how you play with the mind. Okay? The body, you can look after it. But the technology part, you will get lots of it. Go to the exhibition, go listen to lectures. The mind decides a lot of things. You are human beings. And only a human being can change the mind and decide what's in the mind. Alright? So, today we're talking about the mind. How do you manage tomorrow's practice today? All of you want to know. How do you manage tomorrow's practice? Tomorrow's practice in Cambodia, Singapore, United States is going to be different. And you all will feel the difference faster because of what? The internet. Information is always available to you. So, 6 senses and aesthetic dentistry. Why do I have so many lectures in aesthetic dentistry? Number 1, I'm a founder member of the Asian Academy of Aesthetic Dentistry, and I'm a past president of the International Federation of Aesthetic Dentistry. So I'm very linked to all the aesthetic dentists. But there's something in all these famous aesthetic dentists, they do in the office, apart from their work, is the ability to stimulate the senses of the customers when they come and see them. Like for example, if you go to Ronald Goldstein's office in Atlanta, Georgia, which I encourage you to visit, everything is in glass. Porcelain is glass. Everything is beautiful. He even have birds, small little birds in a cage to just stimulate the customer. Remember this famous man?